What if the most dangerous phase of a chronic disease is the exact moment you finally stop feeling pain?
Right. It sounds totally counterintuitive.
I mean, imagine you've been battling this highly uncomfortable condition for years. You try treatment after treatment, and finally one of them works. You wake up, you go about your day, and you feel absolutely fine.
The fire alarms in your body have basically just gone completely silent.
Exactly. And you'd naturally think, I'm in the clear. I don't need to see the doctor anymore. But with certain complex conditions, that silence is, well, it's actually a trap.
It really is.
Yeah. So welcome to today's deep dive. We are looking at a massive stack of medical consensus guidelines to answer a deceptively complex question.
And it's a crucial one.
Yeah, we're talking about vulvar lichen sclerosis, or LS. Specifically, what is the appropriate long-term clinical screening and surveillance frequency for patients with advanced LS who are in complete asymptomatic remission, meaning you feel absolutely fine?
If we connect this to the bigger picture, LS is a lifelong chronic inflammatory skin disease. And for an audience already following the clinical literature, the day-to-day realities and the initial diagnostics, those are pretty well understood.
Yeah, we know the basics.
But the core theme we have to establish right out of the gate for the advanced stages is this. A lack of symptoms does not necessarily mean an absence of disease activity. The disease process can actually be entirely silent.
Okay, let's unpack this.
Yeah.
Because if you feel fine, the most natural human instinct is to, cancel that doctor's appointment. I mean, why go if nothing hurts?
Exactly, yeah.
But to understand why ongoing surveillance is universally mandated by these guidelines, we have to look at what this inflammation is actually doing.
Right, particularly regarding what the medical texts call architectural distortion.
Which sounds intense.
It is. We are talking about profound, irreversible structural shifts to human anatomy. The chronic inflammation in advanced LS isn't just like a surface-level irritation.
It's not just a rash.
No, not at all. It actively alters the dermal layer, specifically targeting the collagen and the fibroblasts.
And those are the cells that maintain the structural framework of the skin, right?
Exactly.
Yeah.
The localized hyperactive immune response constantly attacks the basal layer, which leads this relentless cycle of damage and chaotic tissue remodeling.
Which physically manifests as those really severe anatomical changes detailed in the guidelines, like the labia minora thinning out and actually fusing to the labia majora.
Yes, the fusing is a major structural shift.
And the introital stenosis, right, where the vaginal opening physically narrows, making basic bodily functions incredibly difficult.
Right.
We even see scarring over the clitoral hood, just burying the structure entirely. I mean, the tissue is essentially melting and fusing together under the surface.
The structural integrity is just entirely compromised by that chaotic repair process. Now, when a patient achieves complete remission using ultra-potent topical corticosteroids, the medication successfully suppresses those localized immune cells.
So the attack stops.
Exactly. The inflammatory attack halts, and the sensory symptoms, the severe burning and the itching, those vanish completely.
But the scarring remains.
Right.
That chaotic repair job you mentioned, it doesn't just magically unfuse itself once the inflammation is turned off.
No, pre-existing architectural distortion is permanent. The clinical guidelines are very clear that surgery is rarely an option for uncomplicated cases.
Because cutting into the tissue can actually make it worse, right?
Exactly. It often triggers a biological phenomenon where the immune system aggressively attacks the surgical site, causing an immediate, severe relapse. So the patient is left with altered anatomy, even though the inflammation is chemically suppressed.
I mean, it's like a smoldering campfire. Just because you don't see the flames, the itching, and the pain doesn't mean the embers aren't still burning underneath, silently melting the plastic chairs nearby.
That is a perfect analogy. And this brings up the most terrifying aspect of these clinical updates. The LS can quietly wake back up and resume that chaotic tissue destruction without ever triggering the pain receptors.
Wait, so no warning at all?
None. It's not like a passive loss of function. The disease continues to eat away at the architecture while the patient feels perfectly fine. The deceptive calm of the condition is really its most dangerous feature.
Wow.
You have a localized immune system that has already proven it can permanently alter human tissue. If it slips out of remission and begins that cycle again without causing pain, the patient is entirely unaware they are losing more anatomy until it's just so severe it causes mechanical dysfunction.
So that silent degradation is exactly why medical surveillance is non-negotiable across all the international guidelines.
Absolutely non-negotiable.
Let's get into the actual schedule then. Looking at the consensus documents, the BSSVD, the RCTI, all of them, There is a baseline rule established for the best case scenario patient.
Right, the well-controlled cases.
Yeah. If your disease is well controlled, uncomplicated, stable, and you are strictly following your maintenance therapy, you need an annual clinical review, just once a year.
And the guidelines also specify that this does not require a highly specialized hospital clinic.
Oh, really?
Yeah, a general practitioner or a primary care physician can safely manage these yearly checkups, provided the disease is stable and there's clear communication with the specialist who originally established the patient's baseline.
Okay, I have to push back on this on behalf of the listener, though. If I am in that lucky group, my symptoms are completely gone, I'm diligently using my medication, and I feel absolutely perfect. Why am I taking time out of my life to go to the GP every 12 months? Can't we just say, come back if it hurts?
What's fascinating here is that symptom management is no longer the objective of that appointment.
Oh, I see.
Yeah, the symptoms are already handled by the medication.
Yeah.
This annual visit is fundamentally a cancer prevention exercise.
Right, because the literature shows a documented lifetime risk of between 2 and 5% for patients with LS to develop vulvar squamous cell carcinoma.
Exactly.
Which, 2 to 5% is a relatively small number, but it's certainly not a risk you want to ignore when it comes to skin cancer. How exactly does an inflammatory skin condition lead to a malignancy, though?
It comes right back to that cycle of damage and chaotic repair at the cellular level.
Right, the smoldering embers.
Yes, when cells are in a constant state of rapid turnover due to chronic inflammation, the statistical probability of a genetic mutation occurring during cell division drastically increases. The tissue is under perpetual oxidative stress.
Making it super volatile.
Exactly. Over years, this volatile environment can lead to cellular dysplasia, which is abnormal precancerous cell growth. If left unchecked, that dysplasia could eventually progress to squamous cell carcinoma.
So the GP is essentially acting as a visual and tactile radar system for that cellular dysplasia?
They are. They're looking for specific, subtle structural changes that the patient cannot feel. Induration is a primary red flag, which is a localized thickening or hardening of the tissue deep beneath the surface.
Things you wouldn't notice just going about your day.
Right. They're checking for persistent ulcerations that refuse to heal, or new nodular growths. Because the tissue is already architecturally altered from the underlying LS, spotting these precancerous shifts requires a trained clinical eye comparing the current state to the established baseline.
Okay, so we have our baseline established, one visit a year for the calm waters. But the guidelines detail specific variables that throw that annual rule right out the window.
Yeah, drastically escalating the frequency.
Let's look at the biggest behavioral variable detailed in the source's noncompliance with maintenance therapy.
This is a huge one. A patient achieves complete remission, feels totally fine, and either abruptly stops or slowly tapers off their topical steroid.
And when that happens?
The surveillance schedule must immediately jump to every 3 to 6 months.
Going from once a year to potentially 4 times a year is a massive leap. It implies the biological environment falls apart incredibly quickly the moment the medication stops.
It really does. We are dealing with an immune response that is constantly trying to turn back on. The ultra-potent topical steroid isn't a cure.
It's a suppressor.
Right, an active, ongoing biological suppressor. Without that chemical barrier, the literature shows that asymptomatic recurrence resulting in severe scarring can happen in a matter of months.
So dropping your maintenance meds is essentially like driving without a seatbelt. You might feel fine right now, but because you've removed your protection, your mechanic, or in this case, your doctor needs to inspect the car every few months instead of once a year.
That's exactly it. The active suppression is all that stands between remission and rapid anatomical loss. Now, the other major variable that mandates hypervigilant surveillance is a history of precancerous lesions.
Which is known in the clinical literature as VIN, right? Vulval intraepithelial neoplasia.
Correct.
The sources get highly specific about VIN, dividing it into 2 distinct categories, HPV-associated VIN and HPV-independent VIN. The introduction of the human papillomavirus changes the entire landscape of this disease, doesn't it?
Oh, completely. If a patient has HPV-associated VIN on a background of lichen sclerosus, the progression to invasive squamous cell carcinoma at 10 years jumps to roughly 38%.
Wait, 38%? We went from a 2 to 5% baseline to almost 40%?
Yes, it's a staggering increase.
Why is that combination so incredibly volatile? What makes the LS environment such a fertile ground for HPV to turn cancerous?
It is a perfect storm of cellular vulnerability. Lichen sclerosus thoroughly compromises the local immune barrier of the skin.
Because of all the inflammation.
Right. The inflammatory damage literally exposes the basal cells, which is exactly where HPV thrives. You have an environment already undergoing rapid chaotic cell turnover.
And then you add the virus.
Exactly. When you introduce a high-risk strain of HPV into that compromised environment, the virus finds incredibly susceptible host cells. It hijacks the cellular machinery to replicate, and because the local immune surveillance is already dysfunctional from the LS, the HPV can aggressively drive those cells into a malignant state.
Which explains why the follow-up schedule becomes so intense. The guidelines mandate 6-monthly intervals for the first 2 years, then annually for up to 5 years just to monitor the HPV-associated VIN.
Right.
But then there's the HPV-independent VIN. Does the absence of the virus change the underlying protocol?
Well, HPV-independent VIN is driven entirely by the chronic inflammatory environment of the LS itself. It's usually triggering genetic mutations in tumor suppressor genes, like P53.
Oh, okay.
So the surveillance regime is similar every 6 months for the initial 2 years, then annually. But a critical caveat emerges here for LS patients.
Which is?
A patient without LS who develops and clears a VIN lesion might eventually be discharged from follow-up care. But a patient with underlying LS can never be fully discharged.
Did that because the soil that grew the precancerous lesion in the first place is still there?
Yes, the underlying inflammatory condition remains.
Meaning the environment is always capable of generating another mutation.
Exactly. The localized environment requires permanent observation.
Here's where it gets really interesting, though. Even on the strictest medical schedule, the patient only sees a doctor 2 to 4 times a year.
Right.
For the vast majority of the time, the patient is entirely on their own. So the narrative in these clinical updates shifts heavily onto what the patient must do between those visits to stay in the safe zone.
The guidelines definitely position the patient as the primary caretaker. And the first major responsibility is rigorous self-surveillance.
Meaning checking themselves at home.
Yes. Patients must be clinically educated on how to perform a comprehensive vulvar self-exam every single month using a hand mirror and good lighting. They need to intimately know their personal post-remission structural baseline.
Since they aren't looking for itching or pain, they're looking for structural red flags, right?
Exactly.
Like a new lump, or a sore area that doesn't heal within 4 weeks, or a sudden thickening of the skin texture. If any of those trigger, they bypass the annual schedule and prompt an immediate medical review.
Right. And the second major responsibility is the execution of the maintenance therapy itself. To sustain asymptomatic remission, a patient requires lifelong, individualized maintenance therapy.
What does that usually look like?
This generally involves applying an ultra-potent topical steroid, like clobetasol propionate, perhaps 1 to 3 times a week,
Okay.
alongside daily use of emollients. Emollients serve as a crucial barrier cream, protecting the compromised skin from natural irritants like urine, which can further compound the inflammation.
The clinical updates highlight a massive stumbling block right here, though. The primary reason this treatment fails isn't drug resistance. It's non-compliance.
Specifically, patients underdosing.
Yeah. The guidelines repeatedly flag the phrase applying sparingly. And this stems from a very real phenomenon called steroid phobia.
It's incredibly common.
Patients read the standard pharmacy warning label on ultra-potent steroids that says, may cause skin thinning, and they panic. So they use a tiny, ineffective amount or only use it when they feel a phantom itch, treating it like a mosquito bite cream rather than a chronic disease suppressor.
And that fear of skin thinning is biologically misplaced in this specific context.
How so?
Well, when you apply an ultra-potent steroid to normal, healthy skin, it suppresses the normal function of fibroblasts, which absolutely leads to atrophy or thinning.
Right.
But lichen sclerosus skin is fundamentally different. It is characterized by hyperkeratosis, a pathological thickening of the outer layer, and a dense altered band of collagen in the dermis caused by those hyperactive immune cells.
Oh, I see. So the steroid isn't thinning normal skin, it's actively fighting the abnormal thickening caused by the disease.
Exactly. The mechanism directly counters the fear. The steroid suppresses the chaotic, hyperactive immune cells that are causing the overproduction of chaotic tissue.
That makes total sense.
By applying the correct prescribed amount of the potent steroid, the medication actually brings the skin back down to a normal, healthy baseline. Underdosing allows the deep inflammation to continue unchecked, leading to the exact irreversible scarring the patient is trying to avoid.
So what does this all mean for the listener? The medical consensus is essentially offering a high-stakes trade.
That's a good way to put it.
If you strictly adhere to applying the correct amount of ointment a few times a week, ignoring the generalized warning labels in favor of your specialist's customized protocol, and you take 5 minutes a month to check your baseline with a mirror, you buy yourself the freedom of only seeing a doctor once a year.
Yes.
You actively maintain the dam, you keep your anatomy intact, and you drastically lower your cancer risk.
But it requires a profound psychological shift for the patient. You are transitioning from treating intense daily pain to treating total silence.
Right. You have to stay motivated when nothing hurts.
Exactly. The patient must learn to respect the silent maintenance phase with the exact same rigor and dedication they applied when they were desperate for symptom relief.
Let's do a quick recap to tie all this dense medical data together. For advanced vulvar lichen sclerosus in complete asymptomatic remission, your goal is the annual clinical review, often with your GP, serving as a vital cancer prevention and structural check.
Right.
You maintain that privileged annual status through monthly structural self-checks and relentless adherence to your steroid routine. If you drop the routine, or if you have a history of precancerous men, the risk of rapid cellular mutation pulls you back into a strict 3 to 6 month surveillance schedule.
The frequency of the surveillance is really a direct reflection of the underlying biological volatility.
It really changes how you think about being cured. Do you have any final thoughts for us to chew on before we wrap up today's deep dive?
This raises an important question. If a localized immune condition like lichen sclerosus can fundamentally alter human anatomy and foster a highly volatile environment for cancer, all while remaining completely silent and painless, it makes you wonder.
Wonder what?
How much of our broader health relies on proactive, preventative screening, rather than just waiting for our bodies to sound the alarm with pain? We are biologically hardwired to only react to feeling bad. Perhaps the most critical moments of health management happen when we feel perfectly fine.
That is a phenomenal point to leave on. Just because the fire alarm isn't ringing doesn't mean you stop checking the batteries. Thank you so much for joining us on this deep dive. Keep asking questions, keep checking those batteries, and keep learning. We'll catch you next time.